Then there are the patients who have more significant disease, who are also going to require, after a total thyroidectomy, a dose of radioactive iodine, which is a radiation pill that's swallowed. What happens is patients go on a low iodine diet to try to remove as much iodine from their system as possible, which makes the thyroid cells, both the healthy and unhealthy ones, avid to take up this iodine. And the iodine is radioactive, so it kills off the cells. And so it's actually a great targeted therapy.
You're like light up from the inside.
So what ends up happening is you are radioactive for a few days.
Such a lucky person because I have so many friends, old friends, new friends, people that I've had in my life forever or just a little bit who are so smart, so well accomplished, have so many titles after their last name that people ask me all the time, like, how do you find people, to interview? How do you figure it out? I'm like, well, I'm not even halfway through like my Rolodex, which is something only someone who's 50 understands. But Stephanie Smooke Praw is definitely in there. So disclaimer, Stephanie and I have known each other since we were 5 years old. Yeah. 5 years old in what was then not even called kindergarten, but basically kindergarten. And when I look at you look so much exactly the same. It like freaks me out. And your kids look so like you that it like you when we were that age. When I mean, it just blows me away. I don't know really anyone else where I can say, and your sister's daughter looks exactly like her. It's like the strongest genes ever. So I'm really excited to do this. And I'm excited that I get to talk to you in a way that we normally wouldn't and really ask you questions about like, how did you get here? Why did you choose this specialty? You're an endocrinologist, you're head of endocrinology at UCLA. If someone would have asked me at maybe 5, 6, 7 years old, what would Stephanie Smooke be doing, close to 50? I would have probably said like a doctor, but like the head of her department. I don't think this is a far stretch from where I would have assumed you would have ended up, which is a wonderful thing. And so will you just dive in, like all the things that you do, why you do them, and why you chose this specialty, and then we'll really get into what endocrinology means and how it relates to women's specific health, wellness, and preventive care.
Absolutely. Well, first of all, I just wanted to start out by thanking you for inviting me. Before doing this, I went back and I looked at the guests that you've had on in the past. I listened to a couple of podcasts and I'm really humbled to be here. It's such an impressive group of physicians and researchers and people in the field of women's health. And I feel really lucky to be included on that list of people. So thank you for having me. In terms of what I do now, I'm currently the interim chair of endocrinology at UCLA. I'm also serving as the clinical chief of endocrinology. I'm the director of our thyroid center and director of education for our division.
It's tons of free time.
So much free time. But I think that when I say all of that out loud, it sounds like it must have been a really linear path to get here. And it wasn't. I always knew that I loved science when I was a kid. And growing up, we took Mr. Kegel's class together where sixth grade, we started learning all about biology and cells and all of those things. And I thought it was so interesting. And I kept that interest as I went through. But I was an art history major in college. I took a year off after college and I got a master's in Japanese art history before going to med school. And then I was fortunate to land at UCLA, and I've been at UCLA ever since. And I was a med student here, an internal medicine resident, a chief resident. I did my endocrine fellowship here. And then when I started practicing, I was a clinician who had some interest in research and education and administration, but also had 2 really young kids and wasn't ready to dive into full-time work. I wanted to be able to do things like preschool pickup and, volunteer in the classroom and things like that. And so I had a modified schedule. And as time's gone on, I've been really fortunate to be in places where I've been able to grow. And so my first real area of growth was in taking over fellowship program training. And I did that for 10 years. And what that means is when somebody graduates from medical school, they go into internal medicine and then they want to do more training in a specialized field after that. They do what's called fellowship. And so I got to steward over 50 folks who were developing careers in endocrinology over 10 years. And it's really a privilege to have gotten to
Yeah.
teach them and help them find what they wanted to do. And then I've sort of graduated from there into administration, and I'm now taking care of our physicians. And at the same time, I've been able to keep up research, and I still love teaching. And so I get to lecture in the residency program. And it's really a great way to be engaged in all of the different parts of medicine.
But you don't see patients anymore.
I do.
You
I
do.
do.
You still see
Yeah.
patients.
I
Oh,
still
God.
see patients. So I have a clinical practice
Yeah.
where I see thyroid disease and thyroid cancer patients. And then the rest of my time is spent in administration and research and teaching.
Okay.
But I've
So I have,
always held on to that patient care part of it because it's why I went into medicine in the first place. And
yeah.
I think there's really no greater thing than being able to educate people about their bodies and what's happening and making sure that they're really getting good information.
Yeah. I mean, 100%. That's why we're here for sure. I have a couple back to stop questions. One is, did you know you wanted to be at a teaching hospital? Because to me, that's like a no-brainer. But was that something you thought about when you went, like when you not only got to UCLA, but then you stayed the whole time? Or were you not thinking about it at the time?
So I think I went into medicine without as much information as you would think I would have had. First doctor in the family. I didn't know many doctors other than my pediatrician. And so I came in and I wanted to be in LA, and I, was lucky enough to land at UCLA, and I just fell in love with the culture here. And so I think that it was the culture that really drew me to academics in the first place. I'm not a bench researcher. A lot of the folks that I work with are,
Yeah.
but I do clinical research and I teach, and that's where the academics comes in for me.
Yeah.
But
Which
I
I
think it's
find
just
to be,
exciting.
yeah. I think the first time my husband got a sense of what a teaching hospital was I had my older kids were born at Georgetown University Hospital in DC, which is a teaching hospital. And there were 12 people in the room while I'm giving birth. And he was a little like, what is everyone doing here? And I was like, screaming at him. And I'm like, it's a teaching hospital. They're learning, And I was totally happy about it because I think that's just a different, I don't know. It was shocking to me, I guess, when I learned that many places are not, and sort of the synthesis between clinicians and researchers also teaching and fellows working with them. To me, that just changes the trajectory of their experience and their hands-on experience with your lived experience, if that makes sense.
No, it does. I think the opportunity to be around curious people is
Yeah.
really special. And I think that one of the beauties of being in an academic medical center is that it all starts with the patient, no matter
Yeah.
what we're doing. And if you see something and it's interesting and it's a presentation that's maybe different from what you've learned about in the textbooks, you have a chance to really ask questions and dive into it a little bit deeper. And that's also one of the really exciting things about having fellows is that everything is new to them. And so it really makes you look at every person and every patient as an individual because it is an entirely, new experience for the person who is the learner working with you as well as you. And if you don't continue to look at everything and ask questions, then you fall behind.
Exactly. You stop learning and you stop moving forward.
Yeah.
I love that. I 100% agree with you. And so then why endocrinology? I mean, I kind of assumed you would have been a brain surgeon, but why endocrinology? You're like, no way.
No surgery for me.
Yeah.
So, like I said, my path wasn't totally linear.
Yeah.
I went into medical school thinking I was going to be a pediatrician, and it took me one pediatrics rotation to know that I was not cut out for this. And then I started to explore other things, and it came down to me to internal medicine, which is such a great broad look at everything that's going on within the body without procedures. And I was also interested in head and neck surgery because I just thought it was a really fascinating area and fascinating field. And I finally made a decision to go into medicine. And then I explored from there cardiology and endocrine. And what I realized was that endocrine really gave me everything that I thought I needed in order to have a really fulfilling career. It's intellectually stimulating. The processes that you're studying in the body are so interesting and they affect so many different things going on.
Mm-hmm.
And it's also a field where I can see an 18-year-old and a 98-year-old in the same day. So you're getting to take care of the whole spectrum and you get to build really nice longitudinal relationships with patients. And then for me, the other part of it is you've got a unique opportunity to teach something to people about their own body that seems really confusing and try to make it digestible so that when they're making decisions about their health, they're making decisions based on good information.
So break down what endocrinology is. I know what it is, but a lot of people don't or have assumptions about what it is. I mean, I feel like somehow it's more popular now because people think of kids who aren't growing and they used to go see the endocrinologist. But I don't think that, and because people are so honed in on that right now, but I think just give the broad definition of what it is and how that leads you to see, someone who's just become an adult to a much, elderly person.
Absolutely. So adult endocrinology, most people, when they think of it, they think of diabetes. So we're taking care of patients with type 1 diabetes who don't make any insulin. We're taking care of patients with type 2 diabetes. And then it also involves all of the hormone secreting glands in the body.
Mm-hmm.
So that's the pituitary gland that makes things like growth hormone and cortisol and also thyroid stimulating factors. It's the adrenal glands that make some of our sex hormones, our fight or flight hormones.
Mm-hmm.
It is also the thyroid, which is my area of expertise, which regulates a whole lot of different systems in the body. And then we also focus on bone. And then a lot of endocrinologists, as sort of an extension of all of these areas, also focus on weight management and obesity, as well as perimenopause and menopause.
Yeah. So let's get into a couple of those things because I could talk to you for 7 hours about this, about everything you just said. But first, let's talk about thyroid because that's really your specialty. And tell us more about what your thyroid does, how to know if it's not doing its job, and then what to do if you potentially think your thyroid is not doing its job.
Absolutely. So the thyroid is a little butterfly-shaped organ that sits on the front of the neck, and it's engaged in a lot of different processes in the body. But interestingly, it's not the sole controller of any of those things. So thyroid hormone is produced by the thyroid, goes out into the body, and it's active in a lot of our different tissues. And places where it's active are brain, brown fat, our kidneys, our liver, and our heart. But what it does clinically is it helps to control metabolism a little bit.
Mm-hmm.
It helps to control our temperature tolerance a little bit.
Mm-hmm.
It helps to control how our gut is working a little bit, and also has a role in mood and our periods and sometimes just our sort of overall sense of well-being. But because it's not the only thing involved in control of all those things, what I usually tell patients is if you're having symptoms and you're feeling concerned, you should go to your doctor and have a blood test done. And what we're always looking for is if the thyroid levels match up with the symptoms that you're having, we can blame the thyroid for it. And we can find the right treatment, whether your thyroid is producing too much hormone or too little hormone. But a lot of the time, what happens is there's a mismatch. Thyroid levels might be normal, but people are still having a lot of other symptoms. And I think that that's where it gets tricky because Thyroid issues are fixable, but if it's not coming from the thyroid, then taking thyroid medication isn't going to cure you and make you well. And I think that's where we need to take a really thoughtful approach to see what else is going on with someone.
So really you're looking at them as a whole person and, I guess holistically is the right word.
Yeah, absolutely. And when we're thinking about thyroid function, someone who is producing too much thyroid hormone might feel more anxious and sweaty, and their heart might be racing, and their hands might shake a little bit, and their bowels might be really frequent. They might lose a little bit of weight, and they might have irregular periods. And the way that people always describe it to me is it feels like they've just been supercharged, but not in a good way. So everything is just sort of overly amped up versus if the thyroid is not working, then people tend to feel kind of draggy and tired, and they're more cold and constipated, and their heart rate might be low, and their periods might be off, their mood might be low. And when you hear all of those symptoms, given your area of expertise, you also know that a lot of those are symptoms of perimenopause and menopause.
Yeah.
And so one of the things that we always have to do is tease out where the issues are coming from. And just, labeling something as thyroid, if it's not, only does a disservice to people.
So it's really a tricky area. Like it's a lot of investigatory research on your part as the doctor, but also the patient's part to like really dig in and try to understand what the feelings are. And if there's anything else going on, I would assume it's not very cut and dry.
It's cut and dry in terms of the blood work.
Right. But
Right.
then if the blood work,
So,
like you said, comes back like negative, it's like you're going down another path of trying to understand where the symptoms are coming from, which is,
exactly.
yeah.
And I think that that's why I do a lot of teaching in the patient encounter, and I draw pictures of, how the thyroid is controlled. There's a hormone called TSH that comes from the pituitary gland, which sits right in the middle of the brain, which stimulates the thyroid to do its job. And then the thyroid produces hormone. And then we have a feedback loop where those hormones talk back to the pituitary. And if there's too little thyroid hormone in the body, the TSH goes up, and that's being hypothyroid. And if there's too much thyroid hormone, the TSH goes down, and that's being hyperthyroid. And so I think also that negative feedback loop gets really confusing because people look at their numbers and it's sort of the opposite of what they think it will be.
Yeah.
So I think the opportunity to educate people about what's happening and what those numbers means is really important.
So do you mostly see you and your groups, do you see patients who know they're experiencing some of the symptoms that you mentioned and they come in to look at their thyroid? Or is there a group of patients that have come in for something else and then they're moved to you because other specialists think, no, this is your thyroid?
Yeah, so it can happen both ways.
Yeah.
Some people come to us with symptoms and they want to sort through those symptoms. And some people feel fine and we find things. And some people will go into a cardiologist with a rapid irregular heartbeat. And one of the key things to take a look at when that happens to something is the thyroid function.
Yeah.
And if the thyroid is overactive, then they get sent to us for management of that.
If someone is diagnosed with thyroid cancer, is it usually because they have an overactive or underactive thyroid?
A great question. So, thyroid cancer is really interesting because, in a lot of ways, the structure and the function of the thyroid are totally separate. So, most of the time, we're diagnosing thyroid cancer when the thyroid function is normal. And that's really tough because you are taking somebody who feels completely fine and somebody has noticed a little bump on their neck or they felt something on a physical exam. And actually, gynecologists are some of the best detectors of thyroid nodules and thyroid cancer.
Why?
They are trained to do neck examinations on everyone, and they're just outstanding in their physical exam. And so a lot of the time, that's where the referrals are coming from.
So you literally can feel a node on your
For some people.
throat. For some people.
Where the thyroid is right down in here.
Here,
So
your
it's like
clavicle is, right?
Right above that notch for most
Yeah.
people is where the thyroid's going to sit. And it's a tough exam to do because you have to push kind of hard on the neck in order to feel anything. But if you do feel something, the next thing to do is get an ultrasound.
Yeah.
And the great thing about ultrasound is there's no radiation exposure. And so it's a very safe thing to do. If we do find a nodule, then it's a matter of looking at the characteristics of that nodule and deciding how suspicious we think it is.
Mhm.
So 95% of the time when somebody finds a nodule, it's benign. It's not cancerous. And it's something that we either monitor every year for a couple of years, or we can say to somebody, you know what, this is so benign looking, you don't need to worry about it at all. But 5% of the time, it will be something to contend with. And when we're thinking about which nodules are more likely to be cancerous, we're looking at characteristics on ultrasound. And then we're also thinking about somebody's history. And so patients who have a family history of thyroid cancer, who were exposed to what we call ionizing radiation during childhood or adolescence, and that's radiation for people in their 80s. They might have been exposed to shoebox radiation at the shoe store. So this was a light box that kids stood on to see how their foot fit in their shoe. It was a gimmick. But we know that they stood on these boxes and looked down and the radiation came right up here.
Oh my
And
God.
so, yeah, it's a thyroid cancer risk. There
Yeah.
was, people used to get external radiation for acne on the chest. There were people who would now be in their 70s and 80s who might have had radiation on their tonsils instead of having a tonsillectomy. So we're asking questions about things like that, as well as, pediatric cancer survivors. The other thing, really important for your listeners is that we're also seeing, as people are getting more genetic testing after breast cancer and ovarian cancer diagnoses, there are some genetic mutations that make it a little bit more likely to have thyroid cancer.
Do you know the name? Are they named?
Yes. So we do see more thyroid cancer in patients with BRCA mutations and also PTEN mutations and a few others.
Do you get patients who have had genetic testing and then the genetic counselor has said to them, these genetic mutations put you at an increased risk for thyroid cancer? Or is it like, does that
Sometimes.
happen?
Yeah, that absolutely happens. We've got a
I
really
mean, I hope it happens. I'm just wondering if you experience that.
we have a really strong genetics program at UCLA. And so
Yeah.
we do get referrals that way, but we also get, people who come in because they're reading and they
Yeah.
are looking for information. And I think we have such an educated patient population for so many reasons now. I think so much information is so much more accessible and people are aware. And I think that makes us extremely fortunate, that people are paying attention to what's happening in their bodies. And
Yeah.
what we want to make sure of is that on the flip side, we're providing them with appropriate responses. And sometimes it's, what you read is pertinent for one person, but might not apply to you. And
Right.
sometimes it's, you're spot on. And this is something that we need to look into.
Wow. So let's say someone, God forbid, is diagnosed with thyroid cancer. What does that mean? Where do they go from there?
Great question. So thyroid cancer is one of the few cancers that is not primarily managed by oncologists, ovarian being
Yeah.
one of the other big ones, and uterine cancers. So usually the first step is either somebody has seen an endocrinologist because they have a thyroid nodule. They have a biopsy of the thyroid that's called a fine needle aspiration biopsy. And then they're referred to a surgeon. And the surgeon, who is usually either an endocrine surgeon or a head and neck surgeon,
Mhm.
has the opportunity to decide what the extent of surgery has to be. So 20 years ago, every patient with thyroid cancer had their entire thyroid taken out.
Yeah.
And most patients had their lymph nodes looked at. Now we know that a lot of patients can be appropriately managed with just having half of the thyroid removed, or even under active surveillance, which just means that for smaller tumors that don't look like they're invading outside of the thyroid, we can keep an eye on them with an ultrasound every 6 months.
And what are the implications of having your entire thyroid removed or removing part of it? What are the side effects, I would say?
So for a patient who has their entire thyroid removed, they're going to take thyroid medication for the rest of their lives. And fortunately, we have thyroid medication that really beautifully replaces the hormone that the thyroid was making.
Yeah.
For patients who have part of their thyroid removed, we watch their levels. And a really significant portion of those patients never require thyroid medication. And so we can remove the cancer and keep an eye on them with ultrasound, but they might never require any thyroid medication. Then there are the patients who have more significant disease, who are also going to require, after a total thyroidectomy, a dose of radioactive iodine, which is a radiation pill that's swallowed.
Once or more than once?
So usually once. Sometimes we do end up using it more than once, but that's more rare these days.
How does that make you feel?
The pill itself,
Yeah.
it's a little bit sci-fi.
Yes.
So
Yeah.
my very first patient who I treated with thyroid cancer, who had to have radioactive iodine, happened to be an actor, and he YouTubed his entire experience with his radioactive iodine. And I learned a tremendous amount from this experience. But what happens is patients go on a low iodine diet to try to remove as much iodine from their system as possible, which makes the thyroid cells, both the healthy and unhealthy ones, avid to take up this iodine. And the iodine is radioactive, so it kills off the cells. And so it's actually a great targeted therapy.
You're like light up from the inside.
So what ends up happening is you are radioactive for a few days. And so patients have to be isolated. And if the dose is really high, they get admitted to a hospital room that is draped floor to ceiling in plastic.
Yeah.
And the nurses come in and out in hazmat suits. And
It feels like someone has like Ebola or something. Yeah.
Yeah, it's a super disorienting process. But I also think that that's one of our opportunities as an endocrinologist to make sure that we're giving patients as much information as we can so they feel prepared for it and it's not scary. Yeah. But in terms of how they actually feel, most people feel fine. Some people get a little bit nauseated. Some people have a little bit of tenderness over the front of the neck because that's where the radioactive iodine is working. But for most people, it's just an ordeal.
I did not know that. When did that come about? And like how?
Ooh, long time. Radioactive iodine has been used for a long time.
Just for thyroid cancer?
Just for thyroid cancer. And the reason is that really only 2 places in the body have what's called a sodium iodine symporter, which is a channel that trades out sodium for iodine and allows iodine to get into the cells. And the 2 places are thyroid and lactating breast tissue.
Wow.
Yeah,
oh my
but
God.
This is the benefit of research.
Yeah.
So these sodium iodine symporters were partly identified by researchers at UCLA about 40, 50 years ago. So it just shows the importance of having both the clinician who is sitting in the room working with patients and the people who have the ability to sit down and ask these questions and then figure out how to find answers.
Wow. Okay, that's amazing. I did not know that. That is amazing. I can't think of anyone I know in my large circle who's had thyroid cancer, which is interesting. I'm sure I do, but I do know one of the things I am so adamant about is genetic testing with a genetic counselor.
Mm-hmm.
And I'm not a huge advocate of going and doing genetic testing through the mail unless you're going to really go over the results with a genetic counselor. And to me, this is exactly why, because, it's that what do you want to know from this information and what are you going to do with it? And so if you get the information and then you Google it, I just don't think you're going to be able to really walk yourself through the process and what all this means. And my gosh, if you're looking for one thing and you assume it means one thing, but it could mean potentially something else and you don't deal with that, what's the point? And this is such an example of that. It just really is.
One of the other things about these mail order genetic tests is they're also picking up a lot of mutations where we don't know what the significance of them is. And I think that living with that kind of fear about having a positive result without knowing what it's doing in your body is really tough. And I think that having a specialist who can say to you, I have, taken a look at this and here's where we are. These are the things that we do know about that we can do something about. But I don't know that I would want the information about things that I can't do anything about.
Well, also taken out of context too. So if it's not taking into account your family history, it's not taking into account your own health history. And I think that's part of the beauty or importance of getting that information, but synthesizing it with someone who knows how to understand the full picture and to guide you through it. Otherwise, like you said, there's information that is like just changes the course of your life for potentially no reason because we don't know yet. And that's the amazing thing about the body, right? Is there's just constantly finding new things and I mean, if in the subject of genetic mutations, I mean, in the last 30 years, the number of genetic mutations we can name and talk about and explain what they're doing has what? I don't even know. I mean, quadrupled. I mean,
I mean,
10 times, 20, yeah,
yeah,
thousands. Yeah.
yeah.
There's no number. So, and I also think when you're working with a genetic counselor and a really wonderful doctor, as I have personally, the answer is, or we're not finding anything, but because of family history and because of your health history, we're just going to assume that a genetic mutation potentially exists that we
Mhm.
haven't documented, we haven't labeled, and we don't know about it yet, but probably will sometime soon. That in itself was something when a doctor told me that, I was like, oh, that makes sense, that they at least that they're understanding this is an ever evolving process, an ever evolving game of, understanding it. So,
I think, pulling it back to what's happening in thyroid right
yeah.
now, when we do a thyroid biopsy on a nodule, it can either be benign, it can be cancerous, it can be non-diagnostic, meaning that not enough information to make a decision, or it can fall into what we call an indeterminate category.
Yeah.
And now when you're in that indeterminate category, we send off for mutation analysis.
Oh, wow.
And what we've found is that as these tests have gotten more sophisticated over the years, they have a much, much better positive predictive value. So at the beginning, if we had a nodule and you did a biopsy, they were testing for maybe 10 different mutations. Now they're testing for hundreds.
That's
So
amazing.
now when you get a negative result, you can really feel reassured that it's negative. And if you get a positive result, you can feel reassured that it's positive.
Yeah.
And I think that that's really important. And the one other
Yeah.
thing I wanted to mention is that when you're talking about the mail order testing is not just genetics, right?
Yeah.
It's people having screening for so many different things, and
Mhm.
they get results back that can feel so confusing.
Yeah.
And if you don't have a medical specialist that you can go and review them with, I think that you just end up in a place of tremendous fright and uncertainty. And I don't think
Yeah.
it's healthy for people.
And all the feelings and anxiety and stress that causes is just not good for whatever potentially is going on in your body. I agree. And I always think of our dear friend, Ed Liu, one of our dearest friends' father. He recently passed as well. Was a gynecologist. And I remember with my third son, I was going to have him just about at 35. And I had a weird mutation with my middle son. And I was living overseas. And Dr. Liu was never my gynecologist because I always thought it was weird to see him because his daughter was my best friend. But I would call him, as an adult when I needed like that other piece of wisdom. And I said to him, what should I do about an amnio? Should I have one or not? And he said, well, what would you do with the question is, should you not have it? The question is, what are you going to do with the information that you get from it? And if the answer is nothing, then no. Like, but if the answer is, I want to know because I want to figure out what my options are, then do it. And, he said it in that like very bluff way that he would. But I always think about that because I think like, I've obviously come from a place of I want to know and I want to be educated about as much as I can. But there's this fine line where when you cross over it into a place of like, okay, now I know this, but one, I have no intent of doing anything about it except letting it drive me totally bonkers for either,
Mhm.
the next 6 months or the rest of my life. And I think that because you were saying earlier, you have such well-educated patients and well-educated population you're surrounded by, there's also that other line of like, there's so much information that people have access to, and so much of it is just cuckoo bananas and not not based in science and medical research, but it feels real and it feels right. So I think that's that like give and take, that when we're trying to understand what's going on with our body, we have to sort of understand and figure out where the line is for ourselves. I have one, well, I have many other questions, but one I really want to talk to you about is, and I've asked a bunch of doctors, researchers, clinicians about this. And in fact, when not an actual colleague, but someone who's at UCLA who does breast pathology, how is AI affecting what you do? And how are you looking at it in terms of what you do?
I think it's a great question and it's a tough question. I think that in the patient encounter, the way that AI is playing in is that we've started using an AI listening device to help us craft our notes.
I love
And
that.
so rather than spending too much time while you're sitting with a patient typing on the
Mm-hmm.
computer, you have the ability to have something else keeping track. And I think that that gives you the opportunity for a more authentic interaction. You
Yeah.
can make eye contact, you can really just be present in that
And work
encounter.
in real time. You're not like
Mhm.
slowing yourself down. Yeah.
Yeah. Yeah. So I think that that's a huge benefit. In the thyroid world, they're exploring AI in a couple of different ways.
Mm-hmm.
They're using AI to look at thyroid ultrasounds to see if the AI tools can better predict which nodules are going to be cancerous.
Okay.
And right now, it has to be compared head to head with a reading by a radiologist and then having the fine needle aspiration biopsy results to look at it all together. And then they're also using AI to look at genetic information and how it's playing into being able to take a broader population based look at diseases that we're managing. I think for me, the thing I'm trying to do with AI is not be scared of it and
Good
not
for
see
you.
it as
Yeah.
an enemy or a threat, but start to really learn about it and
Mm-hmm.
learn how I can make it work for me.
I was a breast radiologist, sorry, not a breast pathologist. And she was saying that AI is used in pathology has been incredible. And figuring out like exactly what you said, that I'm not going to be afraid of it and I'm not going to think it's something that's going to, take over. But there are these tools that we can use that can synthesize information in a way that we can't, used alongside with a
Mhm.
researcher, clinician, academic who understands it and can work with it in that way.
Yeah, I think that judgment piece is everything. I
Yeah.
think that if we allow it to be independent without using our judgment to analyze what it's showing us, then we're going to miss out.
My guess is it's this similar as when you were talking about working with fellows and, it's like that you're learning that they're learning and you're learning at the same time that one, every patient is different, but also every way that someone is seeing a patient is different. And so that can't be replicated, at least not for the foreseeable future, in my opinion. But the database, is there. But the tool of understanding that someone's body is different and unique, and then through your eyes is different and unique than even another doctor, that's like the most personalized piece that when used in tandem seems, I don't know enough, but it seems like that would be a great thing, but probably have a little while to come.
Yeah, I think that we don't even know what it's going to be capable of yet. There are people who are looking at using AI to scale unscalable professions.
Yeah.
So looking at the knowledge that one individual has in their practice and figuring out, how you can use like just that person's knowledge base, looking through medical records, looking through the articles that somebody's read and use that to inform decisions and questions. But it'll be interesting to see what happens.
Totally agree. I think it's fascinating. It's a fascinating time, and it shouldn't be scary. It should be, I was scary when when computers and the internet came out, and that was a whole different way of learning and communicating. And I think for people who were a generation above us, it was, bananas. I remember my mom asked me to fax something for her once, and I gave her the paper back after I had faxed it, and she literally said, "You mean I get the paper back?" And I was like, Well, it doesn't like roll itself in a little, cylindrical thing and shoot through the wires. And she just couldn't get it. Like she just, it was so fantastical and like sci-fi, like we talked about. Like it was so crazy that it didn't make sense, which I never thought she was dumb. I just thought it was just so far from how her brain worked and had been taught to work. So, to me, these are all of these amazing things that, now Amina fact seems ridiculous, but that we can use information to move along a little, hopefully not necessarily even more quickly, but in a way that's deeper and helpful. I mean, even having AI take notes when you're talking to a patient seems so minor. And so like, duh, of course, they can do that on Zoom now. You can shoot out your notes from your Zoom. But when you're in a doctor's office and you're talking about scary things and the unknown, and you're taking away a physical object that is like in between the two of you, the intimacy that brings, which I do think allows the patient to be much more honest about what they're experiencing, which in your field sounds like that is incredibly important, like the clinical part of it. Like that's a big deal to me. That's not just a no-brainer. That's like a really big deal.
I think that there's also a little bit of the effect of, like when you were driving carpool and your kids were sitting in the back seat and all of a sudden they would tell you all of these things that they probably wouldn't have told you if you were making eye contact.
Fair.
I think the same thing can be true in the patient encounter. Sometimes they're a little bit more comfortable with that little bit of a physical barrier up. But I agree with you. I think that on the whole, I think taking the doctor out from behind the computer and putting us back face to face with everybody has to be helpful.
I think of, it's funny you said, I literally picture being in your back of your mom's car getting picked up in elementary school. I can picture it like in my head. But I think it's interesting because that you say that, and I wonder so maybe I'm totally discounting what I said before. We have found that women in particular are so much more open about their experiences, their symptoms, what they feel like they need to talk about amongst their trusted friends than they are with their doctor. Or if there's a doctor there, but they're in a forum in which there are people around, they give out much more information than they will when they're in the doctor's office. So I guess it is interesting to see how it plays out. I mean, I've heard some women say really fascinating things that and they've said, I would never tell my doctor. And they're like,
No,
why? And they're like, well, no, that's just too personal, but I'll tell you, So it's kind of amazing. Or I'll tell you with her sitting here too. But like, we do these little mini symposium forums and women ask questions that they just would never ask otherwise, which I love. But you also want to push them. No, ask those questions when your doctor's present and you're really having that conversation.
I think one of the places where that lack of interaction with the doctor and not wanting to tell the doctor everything is in terms of supplements and more contemporary bad things that people are doing. Mm-hmm. And I think that that's actually some of the most important things for your doctor to know. Because we need to know if you're taking something that is going to interfere with the medication that we're giving, or it could account for an abnormality in a blood test that we're doing that might prevent you from having to go and get a million other tests done if we just know what you're taking.
Yes.
And so my hope is that people will share those things with their physicians. And I worry that one of the reasons that people don't is they don't want to be judged.
I also think they don't even think about it. Like, I think there's this sense of, you didn't prescribe it to me. I didn't get it from my doctor. I literally ordered it off the internet. It's not real. So why do you need to know? It's this, I think in some people's head, like, I wouldn't tell you if I was taking vitamin C, like, duh. So why would I tell you if I'm taking X, Y, and Z? But as my husband always tells me, for every action, there's an opposite and equal reaction. And so you have to know. I think that's fascinating. I didn't even think about that. Mm-hmm. It's just, it's that weird in-between world of, is it medical? Is it medicine? Is it not medicine? But it's in my body and it's clearly having an effect in some way. So why wouldn't have an effect in another way?
Yeah. And I mean, I always remind people that the earliest drugs came from plants. And so all
Yeah.
of these things that we think of as natural were the first pharmacologic agents and some of the
Yeah.
first cancer fighters. So we do have to really take all of it into account when we're looking at that whole person.
Yeah. I didn't even think about that part. That's really fascinating. What's like you have all these hats and I know you love them all, but what's the one that brings you the most fulfillment and the most joy? If you can answer that.
Question. I think that I can tell you what brings me the most joy at work, because outside of work it is my family
Yeah.
and my kids and my husband, and that's, of course, what's the reason behind all of it. I think what brings me the most fulfillment always is a combination of the patient interaction and teaching. And if I can sit and model in a patient interaction in front of a learner how to really be an active listener and a strong advocate for my patient, then I know that I've not only helped the patient sitting in front of me, but I've also helped the person who is learning what their own style is going to be as a
Yeah.
doctor.
Yeah. That's what I love that. And I could see you're brilliant at that. No question asked. You're always a really good listener. And it's funny because back at the beginning when you were saying you were an art history major and then you had a master's in Japanese art, is that what you said? I mean, that makes sense to me too. You grew up in an art family. But I also think that there's something beautiful about that and how it shaped, my guess is, how you are as a doctor and this sort of beauty of putting all the pieces together and understanding the origin. Sometimes I think my kids are, older and we are always like, just take those big, good classes in college because you don't get a chance to do it after. And even if it seems to have nothing to do with your specialty, it changes the way you see things and the way you synthesize information and communicate information. And I just feel like it expands your brain in a way that will make it, better and more open minded in some ways when you get to that specialty. And I feel like that would be true with you.
I think it's true for everyone. I think that we're forcing kids to make decisions so early
Yeah.
about what they want to do. They have to know their major at
Yeah.
18 when they're
Yeah.
applying to college, and then it's hard to switch it once you get there.
Yeah.
And I do worry that that takes away from somebody taking the, creative writing class that might open a part of themselves that they've
Mhm.
never thought about before, or, a history class about a random period of time that they had never
Yeah.
studied before that suddenly, gets them asking questions in a different way.
Yeah.
And so I'm the same. I encourage my kids to take that random class and try something and stretch. And even though the stretch can feel scary and it feels like it's maybe causing a detour from
Yeah.
your specific path, maybe it just enhances that path as you go, or maybe you find something else that you love, and that's okay too.
I love that. I love that. It's wonderful, wonderful advice. And you just continue to grow and learn. And who knows, you could change what you love. You could have more love, more than one thing. And you can change that specialty that you're supposed to have at, 18. My God, it's like 16, 17. It's just unrealistic. Well, thank you so much. I know you're very busy and I really appreciate you taking the time to do this. And I know this is a really interesting time in your life. And this has been really wonderful. So thank you, Stephanie. And I'll see you next week.
I'll see you next week. This was a great opportunity. Thank you, Amy.